There are 1,000,000 ways to die. We just wanna talk about it. Codeheads.
Welcome to Codeheads. Today we're on to ROSC Reloaded Part
Part
2.
2. Yep.
For our French listeners.
We're big in France, mostly Lyon.
Huge. And Canada, our French-speaking Canadians.
Québécois, yeah.
Yep. Big. Yeah, we're going to talk about ROSC again. I know that we last week, kind of did an overview. We talked a little bit about some of the neuroprognosticators and, some of the changes from the AHA. But we are going to jump in, I think, and dig into a little bit more. And I did a whole boatload of talking last week, so I'm going to let Mike jump in and start off.
Oh, wow. All right. I wasn't ready for that. All right.
I'm handing the baton.
Okay. I just want to pick up a little bit. We're going to get into neuroprognostication with some more depth today. Obviously very important and increasingly emphasized by the American Heart Association, and we see that with these guidelines. But in the immediacy of ROSC, return of spontaneous circulation, we were talking a bit before offline. In the pre-hospital environment, what we have seen, what I witnessed, what I performed, is we put ice packs on the patient, behind their neck, groin, but we also used to cool the fluid that we'd hang en route to the facility, en route to the hospital. And the way we do that is we just simply wrap the IV tubing around an ice pack. Pretty clever, right? I didn't invent it. I saw someone else do it. Friend of ours. And so, that seemed highly appropriate. Right? We're going to be cooling these patients and we're just getting a little bit of a head start during a 15-minute transport. And however, the AHA does not endorse this. I read the fine print. So cooling IV fluids out of hospital, not recommended. They think they attribute to what they believe is an increased potential for pulmonary edema and rearrest. That is something I am going to investigate further, just to understand the reasoning. I'm not discounting it, without any thought. However, I do want to just mention that with these guidelines, the AHA does not endorse pre-hospital cooling in the method that I just stated.
Yeah, and I think there is a certain patient population, and I don't want to step on your toes and stop your deep dive, but there's certain patient populations that I could absolutely understand that that having cold fluid could do that. However, sometimes I just think that making guidelines based on the few versus the many, and the overall benefits, I guess we just don't want to stop people from doing stuff that they've shown as beneficial, which we say every time, right? Because I know that there's so many.
Right?
Yeah.
CPR is along the same lines. Like, everyone was very upset, especially pre-hospital, that it's not advocated necessarily, but it is situational. And they're like, you're not going to tell me not to do that anymore. And we covered that.
Right.
But
And same with DSED and same with,
Yep.
TTM. Like, there's so many different things. And I feel like I'm giving a big shout out to our pre-hospital, my people, because I feel like pre-hospital is where they really push the bar and they push the standards, and they're seeing lives saved. And so they're doing the stuff that they know is working, and that they're trying stuff. If it's not working, they're aborting it. If it's working, they're going to keep going with it. And so they're really driving the bar for saving lives and for improving outcomes. And so I love that. And I love that they're kind of like, okay, they're guidelines. In the hospital, it's like, we
Thank you for that. Yeah.
Yeah.
But I wanted to show this too before we proceed. I'm very excited. I framed this. That's how proud I am of my certificate of recognition. And there's no HIPAA here. They didn't state the patient's name, just my name. And this is from 2016. Hard to believe it's been a decade, but it's just, again, to show how valuable and what this does mean to us as providers. I'm welling up to bring people back. It really, right?
Yeah.
I just don't want to overstate it. And, so that's that. That was my little frame picture.
That's really nice that you got that.
Mm-hmm.
That.
I framed it. the
Well,
company.
I love that they gave you a certificate, and I love that you framed it, and I frame everything, so
So
even a
that
sticky note that I like.
um so we're gonna get into some neuro, right? Some
Yeah.
neuroprognostication. Okay.
Yes.
Just to mention all four, and then I'll just discuss briefly the serum biomarkers. We have neuroimaging, neurophysiology, then of course clinical examination, which is huge. It's
Yep.
all of it, incorporating in those other factors. So, and regarding serum biomarkers, we have NSE, which is a protein found in high concentration in neural tissue. That biomarker, if it's you know, a good a good outcome, would we want within normal limits in about 72 hours. That's what we want to see, for not a poor prognosis. We also have NFL, which is the neurofilament light chain. So similar, within 72 hours, we want to see that within normal limits. Now, there's other time frames involved, which distinguish NFL and NSE, those biomarkers. And do you want to hit on that?
Yeah, so the NFL is, it's a protein subunit from the neuronal axons. So when axons are damaged, that's when your NFL numbers are kind of a jump up. So that gives us, kind of a snapshot of ongoing um, injury within the brain. So knowing that, we know that it can give us the early levels, like 12 to 24 hours post cardiac arrest, are highly predictive. So it's much more kind of sensitive, and it's less impacted by hemolysis. So if we're drawing labs and they're like, oh, they're all hemolyzed, which
Yeah.
happens, because it is kind of a bit of a bear bug for me when people draw labs mid-arrest. Um, but it like directly post ROSC, if you're drawing labs and they sit there for a minute, like our lights might be off, like a lot of things might be impacted by that, but the NFL won't be. Whereas the NSE is found in neurons. And so that's released when there's any sort of nerve cell damage. And that can take a little bit longer, as Mike said. Usually that's like a 24, 48, 72-hour draw that's really going to give us the levels. So those early levels, if we drew the NSE, it's got a poor prognostic value, and we want to know before 72 hours. So it's much less accurate than the NFL in predicting outcomes after cardiac arrest, and it also is impacted by hemolysis. So it's really just
True.
a not, the NFL is really just more accurate for predicting neurological outcomes in acute brain injury. And it can give us the prognostic information earlier and more effectively. So it's why it's was added to the guidelines. And I know people probably don't really care all about this deep dive, but I found it interesting because I always kind of wondered why they made those decisions and how that was changed, and what it really even means, in all honesty, because I've drawn those labs 1,000 times. Like, I've drawn the NSE, but I didn't really know, you know, what
Right.
it.
And I think you're right. People do skirt over that. Like when even during an ACLS class, we'll talk about neuroprognostication very briefly, but no one really gets into what the serum biomarkers mean. And I agree. I find it fascinating. So if I don't know, it makes me, need to know. And one thing I just want to touch on is what could confound neuroprognostication, which is part of the clinical examination, is sedation, paralysis,
Yeah.
neuromuscular blocks. So things of that nature really can, we got to be careful about their influence, especially if we're going to go talk about, are we at an organ donation phase? Are we end of life care? So
Yes.
the external influences, it's, crucial that we be mindful of them and not let them tarnish or affect our insight.
Right, especially because we do want to be able to, consider every patient that with a poor, predictive outcome for organ donation. So we do really want to think about, like, when's the last time they've been on, when do we stop sedation medications? Like, really and truly, what is their neurological status right now? What is that clinical exam? Are we basing it on, after we tubed them and sedated them and, gave them some sort of
Hey,
blockade, neuromuscular blockade? So we really need to make sure that we're getting a true clinical um, view of this patient.
all right, we can move along to neuroimaging,
Yep.
MRIs. CAT scan. Again, there's more emphasis on that now, and you could even see it on the algorithm itself, the AHA algorithm. So really, it's an absence of restricted diffusion is a good sign. That's what we want to see in terms of a good neurological outcome. But we're not just talking about imaging of the brain, right? Of course, that's of paramount importance for a good neurological outcome, obviously.
Right.
However, we're going beyond the brain, aren't we?
We are going beyond the brain. I mean, obviously, brain is important for the neurological prognostication. However, there is suggestions and within the guideline that we should be doing a full body CT scan or CTA, like head to pelvis at a minimum, to really look at if all pathology is going on with the patient. So if we, as we talked about last week, even though we get ROSC, we want to look at like what are those H's and T's? What caused this arrest? Like what
Yeah.
even happened? We can use that CTA and those scans to help us to figure out, what happened. It's what caused this and how can we prevent this from happening in the future? Was there a PE, tamponade? Is there aortic dissection? Is there any sort of, something, a pneumothorax that might have been prior? But then we can also identify some sort of complications of cardiac arrest resuscitation. So from our CPR, did we cause any fractures and aspiration when we were intubating, pulmonary contusions, and again, pneumothorax, but we'll know that it's a little bit fresher, any sort of hemorrhage. So it can really help us to guide our post-arrest care once we have that ROSC.
I mean, and the irony is you sort of have to cause harm to enable resuscitation. What we're doing is, you have mechanical CPR, even human CPR, 2 to 2.4 inches, 100 to 120 times per minute for, an extended period of time. Damage. There's damage. So I love that head to toe CAT scan, not only for just what precipitated this event, the arrest itself, but also to see what have we done, through no fault of our own
Right.
necessarily, but it's just part of the routine, right?
Right.
So that's an important thing to note because, yeah, again, it's not just about what occurred with them, inherently, but it's what we are also doing during the process of trying to save their life.
Yeah. So we get them back, but we did some damage. And like, how do we put a Band-Aid on that?
Correct.
And how do we prevent it? But in that same vein, we do need to think about, you know, when we're doing CTA, when we are giving, the dye, it is impactful on patients' kidneys. They just had a low flow state. So we do want to think about their kidneys and how they're doing and looking at that BUN creatinine and, as we go in to think about, are we just doing a quick head CT or are we doing the full head to pelvis, full head to toe? Just thinking about that because there are risks, obviously.
Yeah.
Again, there's risks with transporting a patient, as we talked about 1,000 times. They could rearrest, hemodynamic instability, dislodge their tube or, something else. So we do need to look at that
Mm.
risk benefit of the full head to toe. Maybe we just get that head CT quickly and then go, just depending on how the patient's doing. One of the things I really love about the guidelines this time that we did not actually talk about last episode
Mm.
because I kind of forgot and I don't know how I forgot, but there is an emphasis on mental health, both for actually for more than just both, but for patients and caregivers as well as us as healthcare providers. And I know we touched about it earlier, and you got a little feelingsy about one of your saves and appreciation, and that happens to me as well. But one of the big things that they added to the guidelines is that it's recommended that for cardiac arrest survivors, so for the patients and for their caregivers, also known as co-survivors, that there is a full kind of structured assessment and treatment or referral for emotional distress after we medically stabilize the patients and we know that they're going home, and that we're going to be discharging them from the hospital, whether they have any sort of changed abilities or not leaving. We want to make sure that they are in with a professional to get some sort of therapy and continued therapy, not just one appointment and talk about it and keep going. It's a big event. And we've talked about how families stressed and scared. And is my family going to survive? Is my loved one going to make it? And as we all know, there's a difference between making it for that second versus
Yeah.
making it home and being themselves again. And I can't imagine how anyone can be quote unquote themselves
No.
after such an event, in any way, shape, or form. I mean, if it was, any one of my family members, I'd be probably calling them every 5 seconds, like, "Are you okay? Are you okay? Are you okay?"
Right.
Um,
I mean, it's fluid. It's minute to minute, hour to hour, day by day.
and the second piece is also that us as healthcare providers, um, really, we can get burned out with this stuff. It's a lot physically, it's a lot emotionally. And we all know, we've all been a part of it. We all know that some cases take more of an emotional toll on you, whether it's because it something that somebody that reminds you of a family member or there's always just something. And there's patients that live with us forever, and there's, patients that, maybe don't. But it's really important that we always do debriefings after all of these events.
Yep.
And I think that, we are going to be doing a couple of episodes on healthcare professionals, mental health, and the importance of debriefing and whatnot. But it's really important that we have, real debriefings. And if we are concerned about one of our colleagues, that we are checking in with them and that we are offering,
Yeah.
some sort of follow-up for any sort of emotional support using EAP at the hospital or through, I know EMS has access to EAPs as well, using them and leaning on them and kind of just looking out for one another because
Yep.
sometimes it can be hard,
Yeah, absolutely. And I'm glad that prioritization is in fact illustrated. I saw it yesterday in these new AHA videos, the BLS research video that we showed the class. You actually have a segment dedicated to that debriefing just with the healthcare providers, that aspect of it. So I can appreciate that. You can appreciate that. And it's just, we're part of the situation. We're part of this whole, this neuroprognostication. We're involved intimately. So
Yeah.
it's important that we are also addressed in conjunction with the patient and the patient's family.
And we're used to, we build the thick skin, we dig deep, we get through it, and there are times that we, kind of make jokes and we get through it and we keep it light because we have to. But it is important, and I'm glad that I am really glad that it's something that's being acknowledged and at least seen. And I'm sure there's still going to be people that poo-poo it and brush it off as I'm fine, I'm fine. But
Well, they're fine
everyone's not fine
today.
all the time.
They're fine today, but that could sneak up on them in 10 years. Be like, where the hell did that come from?
Right.
you
Yeah,
know? So
for sure.
anyhow,
Yeah, on that happy note, um, we're fine today,
good.
and hopefully you're fine as well. And better than fine. We hope everyone's fabulous. And we appreciate you guys hanging out, listening to us. Again, if you want to reach out, please do so at codeheads411@gmail.com. Our website is thecodeheads.com. And you can listen to us on Spotify, YouTube, Apple, wherever you want, really. Just
Wherever.
find us.
Yeah.
Yeah, be part of our journey, be part of the solution. And we look forward to next time.
Yeah.
We
All right.
appreciate you guys.
There are 1 million ways to die. We just wanna talk